Thank you to everyone for being with us. Since 2016, the University of Texas Humanities Institute has worked in health humanities. We have developed several research initiatives, as well as a new undergraduate certificate in partnership with others, and a new master's degree begin in 2022. Today's panelists and faculty from across the university who are participating. The health humanities is a broad field that brings together health practitioners and humanities-based scholars to improve our healthcare system through attending to the human dimensions of health and healing, being patient and provider experiences, empathy, community resilience, and systematic health disparities and paths to equity. Because we have been working closely together for a number of years, we were able to respond quickly to the coronavirus pandemic by designing a project we are presenting today. Social inequities have led to divergent health outcomes, as well as a range of strategies on the part of communities that are trying to achieve healing and justice during the pandemic. We will hear from a psychologist, Dr. James Pennebaker, specializes in health humanities, Dr. Phillip Barrish, a Rhetoric professor who focuses on ethical issues in health policy and biomedical communication, Dr. Scott Graham, and the Associate Dean for Health Equity at Medical School, Dr. Jewel Mullen. We are delighted to have the opportunity to share our research project with you today and to discuss it with you after our presentations. First, it's my honor to introduce Dr. James Pennebaker. He is the Regents Centennial Professor of Liberal Arts and Psychology, as well as a member of the Academy of Distinguished Teachers. His research and teaching explores how people cope with personal and collective upheavals through expressive writing. He also examines how the words we use in everyday life reflect our psychological states. Author of multiple books and research articles, he is among the most highly cited social scientists in Jamie.
Pauline, thank you very much. It's a real joy to be here. It's been interesting for me because my world is, my research crosses multiple disciplines, and I actually, one of the things that drew me to psychology was, and especially social psychology, was excitement of how do people deal with unpredictable situations. And I'll be honest, and so early in Mount St. Helens, volcano exploded, and I was at the time in Virginia, and I was talking to a good, we decided we should just go and start talking to people across the country in Washington, which we did. And that was the first time I'd gone to that had been affected in different ways by the volcano. And since then I've studied pre-an earthquake, I've studied 9/11, the death of Princess Diana, and on and on and on. And when COVID came, it was one of these things that I just couldn't control myself. I was curious because every other disaster I'd studied had actually been, it was fairly standard ways that people would deal with them. When something horrible happens, the first thing that people do is to collect with others, to go and talk and to hug and to cry and to laugh, etc. This is for a large-scale disaster as well as a personal upheaval. But COVID's so different because the rules are do everything you want except don't see anybody, don't be around anybody. It violates all the rules of what normal disasters are. And I became fascinated, how does this work? So working with several of my students, and one in particular, Ashwini Ashok-Kumar, she and I have sending out questionnaires to thousands, now tens of thousands of people around the world, trying just to get a sense of how they're connecting with one another, how they're coping with it, who's doing well. And at the same time, we've been using the methodology so that we can go online to social media, specifically Reddit. Many of you don't know Reddit, but I encourage you to go, just enter reddit.com and start just writing things, and that way we can study you. In any case, we've been studying frankly, hundreds of thousands of people and looking at how they have been talking about this upheaval over time. And what we have been finding has been quite interesting, because we're discovering that first of all, changes that have occurred. So initially, tremendous anxiety in the way that people talked about it. And then that started to drop. There was immediately after everybody was indoors, there was a very large drop in anger and hostility, which goes against what we would all think. Good news is coming back up. And ways that people are socially connecting has been changing as well. The point is that we're able to get a sense of how people are dealing and thinking with this. And before I forget, let me just show you, get your pen and paper out, because I've got some websites may be of interest. I'll see if I can share this. So here's our first one. This is a website that you can go to the survey that we've been asking people to complete from around the world. And this, in addition to the website itself, there are various places you can go, as you can see along the top, that you can get resources, and you can have access to some of our other data sets. Another thing that's of interest, let me see. Well, I didn't want this to work too well, because I wanted to come across as really folks. There was another website that you can also go to that summarizes some of our findings, and the name of that website is www.trackingsocial.life. And that one, we have a number of blogs that talks about some of the preliminary findings. And one of the things that's most interesting that we've been intrigued by is the high degree of anxiety and social isolation. And what I found in previous research, that people who have upheaval that's characterized by anxiety and social isolation benefit from something that we call and the idea of expressing are encouraged to write for 5, 10, 15 minutes a day, sometimes for 3 days, sometimes just once even. And what we find is that improves people's mental health. The early work was all done with college students, but later on we started to expand this with other groups as well. And now the first study that I published on expressive writing was over 30 years ago, and since then, well over 1,000 studies on expressive writing. And the idea here is if you find time to sit down and just start to write about something that's you, it helps to organize it. It helps you to find meaning to it. It helps you to label it. And essentially what we find is afterwards people work through some issues and they sleep better, they are under less stress, they connect with other people better, and they're ultimately much better off. And now what we started to do is working with some other students and also some colleagues at the University of Michigan and the University of Michigan Medical School. We are instituting a program for expressive writing. And I have another website for this. And rather than to try to fight this web address is www.exw for expressive writing .utpsych.org. And you can go there and get prompts and write and how to do expressive writing on your own. The point is this is from a research perspective, a very exciting time in history to look at our perceiving the world, how they're approaching problems, and coming up with some methods that we think is very exciting to work with people in disciplines to really come together using essentially a humanities relevant intervention to bring about change at scale. So thanks very much.
Thank you so much, Jamie, for getting us started. We will now turn to Dr. Phillip Barrish. Dr. Barrish is the Tony Hilfer Professor of American and British Literature in the Department of English in the College of Liberal Arts, as well as Professor of Medical Education at Dell Medical School, where he teaches a course on narrative medicine in English and American literature at Cornell University. Teaches and teaches intersections among literature, medicine, and the humanities, and serves the Humanities Institute as Associate Director for Health and Humanities. Phil.
Thank you, Polly. I am very excited to be part of this research team and very excited to talk with you all about the project that we're going to pick up a little bit on Jamie's discussion of the power of expressive writing for helping individuals to process upheavals and traumas. I'm going to begin by talking a little bit about something, narrative medicine. Narrative medicine is a field of inquiry and practice that focuses on the role and storytelling play in illness, healing, and healthcare. Dr. Pennebaker has discussed how expressive writing can help individuals process trauma and develop resilience. Other scholars have researched the power for people who have serious illness that comes from sharing their personal stories about their illness with others. That act of telling one's story, sometimes referred to as an illness narrative, sharing one's illness narrative with others, is a way for many people of regaining their own voice, their own sense of identity, and also of creating a connection with people in similar situations. Much of narrative medicine focuses on the importance for healthcare providers of learning to truly hear and become attuned to the stories that their patients, and patients like all of us are always telling stories. We all tell stories all the time. The Humanities Institute has been working for a couple of years on a project here, documenting voices of healing and endurance, which is part of Dr. Pennebaker's project, funded by a small grant from the National Endowment for the Humanities. Communities of Care seeks to incorporate, but also to move beyond narrative medicine's focus on individual experiences. Illness, healing, and healthcare are all experienced not only by individuals, but also by communities of people. Our Communities of Care projects focuses on and underserved communities. And we've been working with a set of community organizations, mostly nonprofit organizations in Central Texas, to collect, and we will soon be digitally documenting stories that reveal how Central Texas communities experience and respond to health disparities, and develop modes of endurance and resilience in response to illness and suffering, advocate for more inclusive healthcare. With the event of COVID-19, we are pivoting our Communities of Care project towards the pandemic and the issues in collaboration with Dr. Pennebaker and prompts to his pandemic project webpage that encourage narrative reflections not only on personal but communal experiences of healthcare access and equity, specifically in relation to COVID-19, communal forms of caregiving in the pandemic. How are people taking care of each other? How are communities taking care of each other? And also personal and communal advocacy in the pandemic for access to needed healthcare services. We're going to work with our community partner organizations as well as members of the communities those organizations serve to pose to deal with these issues to Dr. Pennebaker's website, and we hope to amass quite a number. For those who participate, communities and community members, we believe that the mere act of sharing their narratives will be helpful in the ways discussed above. We also plan to perform high-level analyses that will provide insights that communities themselves can use, and that may also inform public attitude, provider attitudes, and public policy. My colleague Scott Graham's and tools of analysis will be using on the large collection of personal and community narratives we hope to amass. Thanks, and back to you, Polly.
Thank you, Phil. Our next speaker, S. Scott Graham, is an assistant professor in the Rhetoric and Writing in the College of Liberal Arts. He holds a PhD in Rhetoric and Professional Communication from Iowa State University. His research centers on methods for the study of ethical issues in biomedical communication and health policy decision-making. He teaches an undergraduate course on effective strategies for addressing intractable problems in science and health policy. Scott.
Thank you very much, Pauline, and thank you everyone for being here. It's great to have this opportunity to talk to you. So we know research in public health and social medicine that certain community networks predict community resilience in the face of disasters. Right, so different types of networks are resilient in the face of different situations. Strong, close-knit communities of faith, for example, can effectively support a community and a community response in the aftermath of a natural disaster like a hurricane. Strong communication initiatives have been shown to resilience in the face of a wide variety of cancer screening to nutritional support in urban food deserts. What we don't yet know, and what we need to know very quickly, is what kinds of social networks and what kinds of community networks make communities more resilient in the face of COVID-19. This is a very different kind of Professor Pennebaker mentioned earlier. Right? Our typical response to a disaster is to come together close community, is to hug, is to be in the same place. And that's a threat to our health and safety right now. Right? The social networks that have made other types of crises better are becoming a vector for. And so our goal, one of our goals in collecting the expressive writing narratives is to try to figure out the ways in certain communities are able to be more resilient in response to COVID-19, the types of networks that support effective information, risk mitigation, mental health support. The challenge for us is that humanities research is typically very slow, right? We spend a lot of time narratives reading them closely and repeatedly to sort of understand the nuances of the text, the connections that are being made by the authors. And so what we need is a sort of computational support to help us do this faster and at scale, to help us do this in a way that can support a careful and quick analysis of the tens of thousands of prompts that Professor Penn is collecting. And so as a part of this project, we're working to develop an artificial intelligence solution. The Health Justice AI can help us identify which types of community networks are most resilient in the face. The AI has two different component, modeler, which reads the expressive writing prompts submitted to Professor Pennebaker's project and identifies family, friends, neighborhood leaders, healthcare providers, community health educators, and so on. And the modeler uses the participants' data to create network maps of each expressive writing. This only tells us what the community network in each of the different submitted writing samples. We also need to know is which ones are more resilient. This is where the second component comes in. The Health Justice AI also includes what's called an artificial neural network. It's a computer by example. The neural net reads submitted expressive writing samples and compares that writing analyses provided by the human members of our team. So I and Professor Barrish, Professor Strong, other members of the team will read the narratives in the way that a humanist would read narratives, will analyze the features of the narratives in the way that a humanities professor reads those narratives, and then we will use that information on a small sample of narratives to teach the computer program to be able to do the same thing. And so we'll use these social, psychological, and humanistic approaches to identify examples of expressive writing that demonstrate resilience. And then the artificial neural net will be able to use this work to identify resilience in larger and larger samples as we collect more and more expressive writing prompts. In comparing the results from the network model, resilience identification from the neural net, we can start to say which kinds of community networks are at greater risk and which kinds of community networks are more resilient in the face of COVID-19. And we hope that by doing this faster and doing this at scale with the technologies, we'll be able to have rapid community impacts in the communities that are disproportionately afflicted by COVID-19. And Professor Mullen is going to talk a little bit more about what those impacts might look like. But first, back to Pauline.
Thank you, Scott. So our last speaker, the Mullen, is Associate Dean of Equity and Associate Professor of Population Health and Internal Medicine at Dell Medical School. She holds an MPH from Yale, where she completed a postdoctoral fellowship in psychosocial epidemiology and Masters of Public Administration from the Harvard Kennedy School. She currently co-teaches an elective on race and medicine. Dr. Mullen.
Thank you, Pauline. Maybe it's fitting that I'm the last of this group to speak because I'm probably also the last to arrive at UT. And I want to mention that because the first home that I found outside of the traditional Dell Medical School was in the Humanities Institute. And that was so logical for me because of the ways in which we personally and professionally count equity, doing all we can to assure the best opportunity to be as well as they can be, and empathy through an intentionality about understanding the people that we care about and their lived experience. I get a lot about how COVID is impacting communities, particularly vulnerable communities. And one of the things I most appreciate about the Narrative Project is that it's an opportunity for people and communities who are most vulnerable themselves, rather than having us describe what's happening. That's huge. It's a huge opportunity for us to learn how COVID shapes the lived experiences of vulnerable communities, who we hear so much about the disproportionate impacts, morbidity, mortality, and probably the cumulative, the Dr. Pennebaker impacts of multiple traumas over time, not just the social, but the psychological ones as well. So from public health communities, I see the Narrative Project as being like a photo voice or spoken word, rap, other modalities that people use, think, and convey how they feel. And while I might observe or listen, I also know that I don't necessarily always know exactly what people are saying or how to interpret it, which is why I appreciate a project like this, because it takes us from being an audience to really understanding, and to understanding in a way that doesn't just teach us a little bit more, but then helps us think more collectively with the people whose narratives we learn from, to understand what to do, how to support them. As a public health person, a health promoter, I also know how important that is, because we spend so much time telling people what not to do, telling them what their risks are, thinking about how they might recover, thinking about what resilience for them looks like, but once again, without actually necessarily hearing it from them and not necessarily knowing whether or not our messages resonate. So working backwards from narratives actually will bring us closer to the people, their voice, and the language and messages that will be most useful for them. I spend a lot of time trying to make sense of when is a joke not really that funny because it's a commentary on something that's sad. And I'm working with a graduate student in communications right now that's trying to curate jokes and other messages to understand the real message inside there. I'm hoping that through the Narrative Project, we're going to learn a little bit more about that. There's a great defense mechanism. Sometimes it might seem out of place, but maybe there is a real difference. And then from the empathy perspective, I really appreciate learning directly from people, their words, that helps me know how to best connect with them. Meaningful community, and it's not just meaningful for me, but meaningful for them, is huge. Actually huge, because as a doctor, I know how often I could take approaches that might stigmatize people, or potentially and unintentionally stereotype or victimize them. Narrative projects analyses give us a greater chance of moving away from that and moving us closer to what's always been in it for me as a psychosocial epidemiologist. The so what is it that we're going with what we learn? What are the solutions? And then I get to smile and happily say, back into the medical school and say, part of the so what is how I can, as the Associate Dean for Health Equity, continue to embed equity, our clinical work, our research, our community engagement, and continue to refine and improve our curriculum so that our students do an even better job than we do with empathy and with equity. And this was a success. When the next disaster comes, I would say we would be chasing healing again, and not being an ambulance chaser, but chasing another approach to healing.